we are starting with the next session, which is a roundtable discussion on using information for decision making, how to improve efficiency. For the panel, I would like to invite Dr. Raghuram Rao, ADG Central TB Division, Dr. Kiran Kumar Rade from Stop TB Partnership, Dr. Govindan from IIC Director, Dr. Shamim, Dr. Bhavin, Public Health Expert, Dr. Deepak Balasubramanian from PATH, and Dr. Hitesh Verma, STO-Haryana. The moderator for the session would be Dr. Hemant from National Institute of Epidemiology. So I will request the panelists to please be seated. I would also like to invite Dr. Vinay Garg from Central TB Division for the panel discussion. Thank you, sir. So over to you, Dr. Hemant.
Hi all. So I'm Hemant from ICMR NIE. I'll be moderating this roundtable discussion on using information for decision making, how to improve efficiency, right? With a focus on NTEP. So with us, we have Dr. Vinay, if I've got your name right, yes, from the Central TB Division. We have on my left there, we have Dr. Hitesh Verma, who is State TB Officer, Haryana. Then Dr. Kiran Rade from Stop TB Partnership. Then we have Dr. Deepak Balasubramanian from PATH. Dr. Shamim Mannan from WJ Clinton Foundation. And then to my left, Dr. Bhavin Vadera from, USAID India. So let me set the tone. All of us know that, monitoring and evaluation and operational research are key to providing information for decision making. Monitoring is what we do on a day-to-day basis, where the focus is more on your processes and outputs. And monitoring helps you answer the question, are we doing the program right? Then on the other hand, or its brother or sister is evaluation, which is more episodic, right? It helps you answer the question, are we doing the right program? And the focus is more on your outcome and impact of your program, right? Now, beyond your routine monitoring and evaluation, which we routinely call as M&E, we have operational and implementation research, which helps us, provide answers to question what routine M&E within the program doesn't provide. And then we have other sources of data as well. So let me begin with Dr. Mannan, with you. That could you explain to the audience as to what is the current mechanism of monitoring and evaluation within the National TB Elimination Program?
Thanks, Evan. So in the National TB Program, what essentially they're doing it, so the basis for it was a document, which was the monitoring and supervision framework document. And subsequently, it has been updated a lot. And in the National Strategic Plan also, they had a result framework, a chapter is there. In the previous one, which is undergoing revision. And then you have very clear deliverables in terms of each year what the national program would be doing. But the basis of all of this is NICSHE, which is a case-based, web-based MIS system, which is used by the National TB Program. Other than that, the focus is on how to consume that information, which broadly looks at the processes and the outcomes. And also there are many other elements which are not really part of NICSHE, but then gets consumed, especially the whole process of data collection and which eventually gets fed into the NICSHE. And then there are many unanswered questions which come from the operation research. Then you have also something which is not really measured in NICSHE, which is the advocacy, communication, social mobilization, which also looks at what the community processes are, how the communities are coming in, which might not be directly in there in NICSHE, but then that also gets measured. And on the other side of it is the consumables, right? Be it on the drugs or the diagnostics. So that itself is again measured and subsequently goes in for the quantification. So broadly, this is how it is in the National TB Program.
And all of us know we use a acronym called as QPR, quarterly performance reviews, and many of us have our set slides which Nikshay reports produces, and based on that programs are reviewed. So Shamim has covered the whole, from MNE to ORIR to other sources. So let us come to Nikshay. Dr. Vinay is with us. So Nikshay is the case-based TB information management system, and it's electronic, it's web-based of the National TB Elimination Program. So how is it helping in providing information for decision making and improving efficiency? I'll add one more question. What are the recent the innovations that are being planned? And I'll add one more, a comment on the data burden for the staff in the periphery. Yeah, over to you.
So thank you so much for the questions. So I'll come to the question. The first one was, there were three. I forgot the first one.
So how is Nikshay helping in providing information for decision making?
Yeah.
And with a focus on improving efficiency.
Yeah. Yes. So as Dr. Shamim told, that most of our data is on the Nikshay platform itself, right from the start, wherein we enlist an individual for a particular test as a presumptive case. So the information collection begins from that particular stage itself. The patient is tested, the results get entered. So all these information is within the understandable limits. I believe everyone is aware of that, how the information flows and what all people are able to access it at all levels of care. So apart from this, we are all aware of what Nikshay is doing and how we are making the decisions. What I believe is the non-core information, what we presume to be non-core information for TB, like I would say for that, some type of comorbidities which we are entering. So something innovation you are saying. So what I always see is what routinely we are analyzing. What non-core information we are getting about, is the patient hypertensive? Is the patient diabetic? Is the patient coming from poor socioeconomic strata? Is patient having addictions? Which are the indicators which will predict an adverse outcome? So this part of Nikshay data, which we are presently focusing on, which has also helped us to frame strategy for the present campaign, the comorbidities and the vulnerabilities which we have defined. So we are trying to use this part of information to strategize our approach going ahead in time, how to focus either in spatial terms or in population groups, which are more likely to yield us results. Once a person comes into our system, diagnosed and put on treatment, the system is robust enough to monitor it quite well till the time we have a end of treatment. What we lack is how we use this data to anticipate where the future cases will come, or when the cases have come, which of them are more likely to go towards an adverse outcome. So that are the two things which I say, which we are looking towards. And coming on to your third part, the burden of data on the peripheral health worker. I believe, like, when we will go for more and more digitalization, and the duplication of data would be reduced, like NCD program is collecting data on diabetes, hypertension, etc. We are also collecting, the person is same. So environment people are connecting some data on this socioeconomic people are connecting. When we have common databases integrated, and once we have entire population pooled in that database, whether it is accessed by some NCD, whether it is accessed by this, and our inputs and our interventions are also included, and also when they did their, when the NCD program did their blood sugar, what they intervene for, when these things get embedded in the system and which is mutually usable by all, I believe that would be a critical point when the burden of data entry would start to come down.
Excellent. So I'll just take it forward. So Dr. Kiran, to you, you have worked a lot in Nikshay. So there is a principle of HMIS that what variable is captured, if it is not accessible for the person who is capturing, it is a principle of HMIS that what I enter, I should be able to access. So there are some variables which are, if a state enters as a non-mandatory variables, which if the state enters, they are not able to get that in their reports. So what is the way to work around that? For example, your fasting blood sugar and these kind of variables are non-mandatory. So if a state has its own initiative and documents glycemic control, they're not able to retrieve that information in their reports. So would like to have your response on that, please.
So thank you, Dr. Hemant. Frankly speaking, Nikshay has received 2 awards, by the way, the government awards, and one of them was e-governance award, other was the Scotch award. But at the same time, I must admit, with apologies, Dr. Vinay, if I am too straight by saying so, that there are certain things which Nikshay should have learned from other systems in the country, like MCTS, which was there on the plan, but somehow it did not happen. And the best part of MCTS, which was overlooked, it is still there in the plan. I'm coming to your point that there is a set of variables which are common for the whole country, which all the states must report. Then there are some 80 or 90 variables in MCTS, which are mandatory for every state. And it's a common system. So every other state, the RCH information of a pregnant mother right from the beginning till the end is entered common, made available. And on top of it, there are states who have added 20 variables. There are states who have added 50 variables. Gujarat, which has started the MCTS basically, a starting point, they have 150 variables. Tamil Nadu, 148 variables. So that is the model wherein the kernel of the particular program with a bare minimum mandatory variable is common for all the states, and they can access it as it is. And the rest will be accessible only to which they are contributing, will be accessible to only those states, and it can go to the center. And they even the storage of information and talking with the central server is in such a way that the state can modify the way they want to for the additional variables in addition to the outputs. That is a part which was overlooked by the Nikshay as of now, and I think it is high time that we are in a phase of entering into Nikshay 3.0, and I think it will be taken care of. Sorry, I'm saying this on the behalf of Central TV Division, but yeah.
So for variables which are not compulsory, but if the state wants, based on its initiatives, to document.
So I'm coming to that point. Finally, I give you the pretext, because this is the thing why there are certain things not made available. So once that happens, the whole database will be and must be accessible to the states. As of now, it is not there. I told you the technical reason behind it. And the most important point, you said state, but sorry, the data by the definitions and the law IT acts of Government of India, both its amendment also clearly says the owner of the health data is the patient and the citizen, not the state, not the district, not the government. So we should keep that in very much in mind, that the ultimate ownership of the data is with the patient. And I think government overall is in a very good position right now to create the EHRs and EMRs, the connecting IDs of ABHA, based on which all the point which Dr. Vinay said will be made available in terms of NCT data, this data, that all the packets will be clubbed towards and pivot around the ABHA ID, and then the ownership will be with the individual. And the moment the individual goes to any provider anytime, with these simple identifier, the whole information will be shareable and available all the time in real sense.
Thank you, Dr. Kiran, especially on the clarity that there is an option in future that if state wants to download the modifiable data that they have entered, which is not mandatory for everyone, the mechanism is being explored so that innovations can be led and documented in Nikshay. Thank you very much. Dr. Balasubramanian, with your experience in South Asia, we have discussed about India. would you be able to share some innovations about how information is being used for decision making in TB programs in South Asia other than India? Over to you.
Yeah, thanks, Dr. Hemant, for the opportunity. So I like to share observations from India and South Asia, and where we have already had some experiences and also observations from the other countries. So like to categorize into 5 buckets, and the processes being: one is data-driven decision-making culture. So under a CDC Expand Elevate project in India and Vietnam, we have been building capacity of the local NTP staff to look at data and take decisions and inform the program managers. So this has been a replicable model, and we are seeing outputs from India, wherein we have trained more than 400 staff, and 200 have been identified as data champions, who are in turn looking at the data and informing decisions for the local action. And similarly, this is being expanded in Vietnam also based on the learnings from India. And second, my colleagues already touched upon, one is digitalization. So all the countries neighboring have been digitalizing data and looking at a single platform for TB. So they have separate platforms for TB, be it DSTB, DRTB prevention, etc. And some being case-based and some being aggregate. So countries are looking to digitize data on a single platform. India is at the forefront, and other countries are in the pipeline to have a uniform platform for TB. And digitalization is a cornerstone for information seeking, and this can be based having logic-based models and AI-based models, which can be used for geo-mapping and different solutions built based on the data available. And third is about decentralizing entries. So people are looking to decentralize data entry from the district and sub-district levels. So in India, we have a couple of states, Maharashtra having the CPHC platform, which is building, and Rajasthan CHIP platform. So the local healthcare workers are doing the entries and decentralizing the data entry from the district and sub-district level to local level. So it's more real-time data entry with more prompt feedback. And fourth is about democratization of entry. So as Dr. Kiran mentioned, the person with TB, the citizen, is the owner of data. So we have person-facing applications also in India, and similarly other countries also have community-based applications through which they have access to the data platform. And last is about diversification. Dr. Vinay mentioned about other programs. So we have the Ayushman Bharat Digital Mission Platform, wherein the ABA ID is available, and repositories for health systems, etc. is available. So this enables exchange of data between different programs. And similarly, we are trying to apply the learnings in Zambia also, where different portals are available, and there are different IDs for the health facilities and patients. So we're trying to have a uniform repository through which data can be shared across these different platforms. So thank you.
Thank you very much for that. Now let's get out of NTP. I'll ask this question to my colleague to my left. How are learnings from various development sector projects contributing to decision making? And if you can speak in general, but also specifically with reference to NTP. Yes, Bhavin.
Thanks, Hemant. So I think, again, to set a context, right, why the developmental sector projects get into place, right? So particularly in India or any other country, right, where any newer activities need to be tried out, any process innovations that need to be worked upon, any operations which are going on where we need some changes because they are not efficient or because some challenges that has been observed when we want to solve it, right? So I think depending on the stage, what kind of interventions that the project is, right? It can be, say, for example, the program or the project can be of the stage of the ideation, or it can be of the stage of the experimentation or implementation, or maybe adaptation, like in a country like India, where our national strategic plans and our guidelines are, they have defined everything. What we still require is that state to state or geography to geography, there are variations where we require some adaptation. So I think, so based on what kind of project it is, the monitoring evaluation systems or data systems need to be designed right up front, right? And over a period of time, we have experienced that the traditional approach of, theory of change, and then we set up some input-based parameter processes and output parameters. Now there is more and more requirement of the agile and more adaptive monitoring, evaluation, and data systems, right? And that's where I think in the development sector projects, there is a lot more role of the documentation. You can see, and that's the difference between what we are usually doing a lot more in the programs as compared to the projects, where they have dedicated documentation MEL experts who are documenting each and every processes, and that helps to make the adaptation or making the changes in the method also, or the intervention as well. Last point I would like to add is, I think, and that's some of that we have experienced from some of the interventions that you yourself has also conducted, is how we can gel the documentation, monitoring, evaluation along with the research methods, so that at one end we can keep documenting, on other end we keep making it more scientifically rigorous. And I think some of the examples from TNCAT or many others, where those are now very well documented, and then that can be looped in, and that create a new research questions where again gets into the systems, right? So I think those are in the project setting, it becomes easier, I can understand, as compared to the programs where the scale is so wide. But I think a few of those learnings would always be useful to start working at some of the state levels or the district levels, where the data systems and the quality and the implementation maturity is much more better as compared to rest of the geographies, I would say.
So I think what I get is that the projects which are led by developmental sectors or research organizations supporting programs, they can answer some aspects of program which there are implementation gaps which the program has tried, but they're not able to address. Okay, excellent. So going beyond routine M&E, coming to operational and implementation research, that's something which I really work in. So we have a state TB officer there, Dr. Hitesh, from whom I have personally learned a lot. So as a state TB officer, how has, you do M&E, right? But how has operational research and implementation research helped you in your day-to-day decision making? So let me just clarify what operational implementation research is. Any research, there are many definitions, but any research that is done in routine program settings with the aim to improve the program performance, right? The context of the program is key. So how has operational research, implementation research helped you in your day-to-day practice as a state TB officer?
So Haryana is quite uniquely placed as the second highest number of TB prevalent cases for all ages and forms in India, apart from Delhi. So we have we have huge challenges all over. We have a prevalence of 261 per lakh cases as compared to 198 for the country. So even then, if we look at the prevalence of 477, the incidence rates comes to 318 per lakh. So there's a huge gap still remaining. So when we started the year 2024, we were well aware of that. We need to reach the targets. We need to have more presumptive tested for tuberculosis. So by June, we were around 1900 to 2000 tests done per lakh population. So at that time, I entered the sorted program as an operational research and implementation. So as a part of the program, what we did at the peripheral level was we did a three-pronged approach. One, identify a person at each non-designated microscopy center as a nodal person to work for TB. He was trained to identify a TB patient by a 4-symptom complex questionnaire, and as well as making a P for all those patients. After that, those patients, they were marked whether the samples were coming for those patients or not. And if the samples were not coming, the government took cognizance of that, and we sent our worker to the patient's home and collect the sample from home. Obviously, all this was incentivized. All the samples, they were sent to DMC PHI where they were tested, and after becoming positive, those samples were taken to NAT centers. But what the change we did was identify a nodal person for each non-DMC PHI. We had a three-pronged approach. We ensured which community volunteer will take a sample from which non-DMC PHI to the DMC PHI. And if the sample is not taken by the community volunteer, it has to be taken through India Post. And for the patients who are not coming to the non-DMC PHI to collect the samples, we sent someone to their homes to collect the samples. And by this simple approach, we had an increase in presumptive TB cases enrolled from around 4,000 per lakh population to around 6,600 per lakh population. And the non-DMC PHIs, which were not enrolling, they jumped from the one who were started enrolling, they jumped from around 11% to 22%. The sputum sample transport increased from 11% to 22%. Even if we look at the results, the non-DMC PHI, they performed relatively better as compared to the DMC PHI, with approximately 1.5% detection rate throughout. Even the study was done around July, August, September. In north side of India, the number of notifications come down during the winter season, something we didn't see in the non-DMC PHI as compared to the DMC PHIs.
So you did this as a part of your sorted course?
Yes, I did.
So our question is, would you have done this as a routine?
No, I would have
sorted was not
never
there?
even thought of it. But more than a sorted code, it actually helped the patients in the field. So that was really beautiful about it. When everybody was talking about 100 days Nikshay campaign and so we were at the parallel system working towards a passive case finding for the same. So that one step, the number of notification have increased to the highest ever possible in the last 10 years.
So thank you very much. So Sorted is WHO TDR accredited and coordinated a model for building capacity in and conducting operational research, where program managers like him are the participants or the mentees who come over and they go through mentored ORIR projects. And as a part of one of his mentored ORIR project, he is looking at improving enrollment of presumptive TB from non-DMC PHIs, improving enrollment of presumptive TB from primary PHIs, and therefore monitoring over a period of time whether they are contributing more, whether their test positivity is improving, and as a result, is it helping in increasing notification or early case detection. So that is year one findings. We are hopeful we will find out what happens.
Early actually, since it's been only 3 months since the implementation. So in the coming months, definitely more and better data to come, sir.
Excellent, excellent. So now what I'm going to do is I'm going to get back to Shamim, right? And I'm going to ask him, beyond MNE, beyond ORIR, where else does NTP, get information for decision making?
So I wouldn't say that I would want to add more data points to it, but then clearly what I do is I'll try to illustrate an example of a province where they have tried to look at various data systems and how best can they deliver this service. So this is tried in Mizoram in Northeast India, and what they did was not only looking at what is there in Nikshay. So what they did was they also started looking at various other data sources which is available in the environment, and they reached out to everyone, not only restricting themselves to the health system. So what they did was they reached out to census and also to the Space Research Organization.
Okay.
They looked at the geospatial data, looking at urban, rural, population. They also looked at mobility data, where people are moving, not moving, what is happening. They also looped in the sentinel surveillance sites, which the health system has.
Okay.
And they looked at what is happening, like if there is a fever somewhere. So is this fever for TB or not? So basically information was available, but it was being consumed by only the respective programs. So an attempt was made to see what it is. But what is also interesting is the way things are evolving. Like many of us here have these wearable devices, which also is collecting a lot of information. Like, is there a way in which you would want to use this? No. So one of the things which has been tried a lot is also on looking at cough. So if you ask a doctor, like, are you coughing? There's a question. Many of the places, it is what I was telling earlier also, now cough in many places is a way of life. Right? If you go to my village, people, when they enter the house, they cough. And then
say that I've entered the home.
Exactly.
Right?
So the thing is, there is a lot of information which is available, but then how best can we utilize it? It's a very challenging task to answer, but then yes, Mizoram, they did attempt. It had been showing promising results. That's what I can say.
Permit me to add one more example. In Rajasthan, we have this thing called as Community Health Intervention Interface Platform, CHIP, where the annual household survey data, which is entered by the auxiliary nurse midwife, is captured in an e-portal. So now you'll say, what does this have to do with TB? So now, sitting at the state, you have proportion of villages that are multidimensionally poor, proportion of villages with high, numbers of marginalized communities, proportion of villages that are 20 kilometers far away from a nearest primary healthcare facilities, and the combination of all these things. So this could act as, targeted ACF, right? So there are multiple sources. I'll come back to, yes, Dr. Vinay, yes.
So one portal which integrated disease surveillance program is building on is IHIP. You said CHIP. So integrated health information platform, and they are regularly collecting information on around 21 or 23 outbreak prone diseases in real time basis. So as Shamim was saying, that a fever case could be a viral fever, could be a COVID, could be bacterial, could be tuberculosis. And apart from those, they are also looking at clustering of such cases and various other parameters which might be contributing to those, like infection from a water source, acute gastroenteritis, or a migration of a person. So eventually, when we migrate towards such kind of systems where all of us as health workers are able to access the data which is relevant to us for our, so probably we are moving in the right direction. Not probably, I would say certainly we would be moving in the right direction. And these innovations in terms of hotspots, what was first used for very fast evolving diseases, like the disease where the onset and death or the adverse outcomes are very short. So we had to act fast. Then this term evolved, and now we are even using for even slow diseases where the death is not an immediate outcome, but that helps us in differentiating those areas, those populations in time, place, and in occupation terms also, occupation or population parameters, like urban population, what in urban slums, or within a population group or within an occupational group, silicosis, where the mines are more. So those become by themselves of their vulnerability, become the hotspots for us to seek active. Probably we are moving in that direction in terms of.
Excellent. So if I may add a question, coming back to Nikshay, sorry. What steps are we taking to improve the quality of data that is getting into it? What are the routine mechanisms? Because we are completely relying on it, believe me, to do a lot of analysis, about from presumption all the way to treatment outcome declaration. Sorry if it's a difficult question.
No. So I would take support of Dr. Hitesh in that, because what we do from here, our side is we make parameters to make it more distinct. Like we define things. This will be as a new case. This would be a retreatment case. This is a pulmonary. This is extra pulmonary, age, gender, etc. We specify, try to be as specific as possible. Second thing is we try to make ambiguity or subjectivity as less as possible. Like one has to add an information, then has to add an information. It is not that I'm not able to collect, then I will not add, and the data will get entered. So we make certain mandatory fields. And third thing is we try to review. When we review, then we try to find things where ambiguity comes in. So we try to make it more precise. But I'll ask Dr. Hitesh to give a field experience.
Obviously, sir, Hello. You're quite right, actually, sir. Sometimes the data is entered quite wrong, but sometimes Nikshay gives us the ability to change the data. Some false report is there, so a patient is wrongly diagnosed with MDR. We are not able to change that kind of data. But apart from that, sir, we have regular SIE systems where we go into the field, have a kind of an audit of what kind of data, triangulation of data is done, one from the microscopy centers, the NAT centers, and the registers, and match it with the Nikshay. So that's we have kind of audit systems in place, but at times it does happen. Non-legal entities, they also get entered in Nikshay.
If I may put a direct question is, are we checking a random proportion of presumptive enrolled, random proportion of those notified, to check what proportion, because there are always targets, unfortunately people on the ground, they're provided targets. So to meet those targets, sometimes they may add some extra, because I have to meet the targets. So are we having some kind of mechanisms to cross-check at least 1%, 2%, 5%, or annually 5%?
Not exactly, sir. I think we need to have...
Yeah, please. It was an open question, yeah.
Sorry. I should not be overruling the program, but being a close associate, I've worked with the program for more than 2 decades. And when it comes to Nikshay, for last 15 years, for initial few years, there was a very routine activity called Central Internal Evaluation, and at the state level, State Internal Evaluation, wherein districts on a very regular basis would be evaluated, and data triangulation as well as comparing it with Nikshay was a regular activity. I see most of the CIs were replaced by another activity, joint supportive supervision at the national level, still going to the districts, but the frequency was reduced, especially after COVID, for certain obvious reasons. But the structure of evaluation was also kind of more comprehensive, because the number of initiatives the program has taken, that data triangulation was slightly minimized. But the state internal evaluations continues, and most of the states do that. So it is a regular activity in most of the states, if not all. But coming to the specific, very specific activity of data quality, there are two opportunities. One, we have colleague from Global Fund, and also, as you know, World Bank also has a certain milestones, of which the verification has been and is being done by WHO India for last 10-12 years. And that data quality verification is a very robust method, and it is done by two methods. One is the huge network of WHO consultants, which are public health professionals, 150 plus, highly trained, skilled across the country, who are actually going and collecting that information, verifying the data on all the dimensions. And that's a wonderful activity regularly happening for World Bank on an annual basis. So still, that numbers that even the patients are visited and the data is cross-verified. The regular other records with lab registers, NAT registers, TB registers, notification register, all is verified, certified and signed by the WHO consultant and compiled. That is one. And the second, we did not stop it here. Under the same milestone verification, WHO extended, WHO country office extended its verification, milestone verification, wherein ranging from 2,000 to highest, what I saw 2 years before was around 45,000 patient records have been verified in each attempt in two manners. And these are randomly selected samples out of different states, including the non-World Bank states. I mean, it's across the country. One is through a call center, which is existing call center, wherein the information is verified for all those 45,000, 50,000 individuals. And 10% of it is physically verified by a third party hired by WHO India on a regular basis. And now I don't want to drag into what are the quality issues, how rectification was done. But in short, we could identify the systematic issues even in Nikshay, corrected them, and the discrepancies resolved, and the witness, maybe there are different reports accessible to the individuals. Most of them are on the website as well.
Excellent.
So data quality is a robust thing. Still, I never saw a program claiming we have 100% accurate data. No one can do it actually, but it's a very highly credible data. That's what I can vouch for. Thank you.
So excellent. As long as systems are in place, we can continue to improve. Excellent. So yes.
The TB program over the last 10 years, all would have noticed, is becoming more and more open and adaptable to change. Now, from being a very pragmatic, didactical approach, then the program is imbibing whatever the feedback is coming, including like developing our data system, treatment protocols from alternate day to daily regime, everything, whatever diagnostics. So that's the resilience of the program, which I think is making us adapt all those things, and we will continue to adapt whatever comes.
Dr. Vinay, one thing which the program has done really well is that putting it out as to how many patients we are notifying. Anyone can go and check for a time period, for a district, for a TU, how many have been notified, how many are public and how many are private. And I think we should strive towards making this more and more open, so that it also opens avenues for researchers to answer priority research questions and inform the program. So I'll just have two more questions. If organizers, please tell me, we have 10 more minutes. So, Dr. Balasubramanian, you have worked as a national consultant in NTP in Bihar, and you have also supported them. Like as Dr. Kiran told, in going to the field and doing cross checking. In generating this information for decision making, do you think there is a data burden on NTP staff on the ground?
Thanks, Jay.
Or if there is it worth it? Yes, we understand. So what is that? Is there a data burden on NTP staff on the ground? Over to you. Yeah.
Thanks for Hemant for the question. So I think over the past 10 years, 12 years, we have seen the evolution of the MIS systems. So we had Epicenter earlier, which is quarterly aggregate reporting at the district level, and followed by Nikshay version 1.2, Nikshay version 2, which is presently running, and 3.0, which will come in the future. So in the context of the program is evolving, and we have new initiatives which are being rolled out. And definitely over the years, we have seen increase in the data burden with the NTP staff. So how this can be addressed is one at the staff level. So we can increase capacity for them to consume the data. So we have been building capacity of the staff also to read the data, and what has been achieved earlier in 2 days is being done in half a day, half an hour, with newer tools in Excel, be it Power Query, basic pivot tables, etc. So that efficiency of the staff has been improved to consume the data. And second, we've also observed in the field in terms of access to the devices. So staff who have access to tablets and laptops are able to consume the data in a much more efficient manner. And for example, in one district, Kabirdham in Chhattisgarh, they didn't have access to the laptops, while Navi Mumbai in Maharashtra did have access. So we see a stark difference in terms of utilization and consumption of the data. And third, we have new initiatives which are being rolled out. But at the end of the initiative, we just let the variables remain. So let's say JSS, which was rolled out earlier, we do have variables in Nikshay, and the variables continue to remain. And as on date, we may have close to 3,000, 4,000 variables. So it might be a good situation to take a step back to see what variables are necessary and rationalize them so that the burden at the field level is reduced. And lastly, we already covered previously in terms of decentralizing entries and integration with different platforms. So CHIP, you mentioned in Rajasthan, we have e-coverage in UP, etc. So some common platform which can share variables across the different platforms so that we don't have multiple data entries also, and same valid information is available across the program. Yeah.
Excellent. So my last question, and this is for both Bhavin and Dr. Rade. How can NTP coordinate with other departments, other sectors other than health, to improve its service delivery and efficiency?
Maybe I'll go on long, but so I'll request Bhavin.
Okay.
Then I'll.
Right. So now I think we have already covered a lot more component on the health. I think both Dr. Vinay and other colleagues have mentioned about it. But on the non-health sector side, in the today's morning panel also, there were discussions around now there is a need of moving towards understanding the determinants of the diseases. And if the departments, the relevant departments where these determinants who are being handled are engaged through their information system, it will be helpful, right? I think very pertinent question you mentioned about is the data burden, right? And to avoid data burden, we need to understand that those departments, say whether, for example, we want to talk about the climate, or we want to talk about the air pollutions or the nutrition. So those determinants that we want to address to, their information system we need to understand, and then there should be way to exchange information rather creating. What right now we are doing is we are trying to add all the information within our own system because there is a lot more control and things like that. But over a period of time, we need to make a judgment over the control versus whatever the information that we may have and how to use it. And I think some of the other factors that we keep doing is that whether we need to have those information on the frequency at which we are collecting the information of TB or the health. We may require the frequency of 6 months or yearly. So then we get that information from that particular department or that frequency only, so that we can manage, and the epidemiologists like you and others can help the program to make use of that data, right? Why we want to finally collect it to make sure that we use it and do those interventions. But I'll request Dr. Kiran to.
Kiran, would like to add something?
So you talked about ministries and for different determinants. there is a scope for even the macro level aggregated data and information, and similar to what WHO tries to do at the global level, at least Government of India has tried to do it at certain levels. And there is intersectoral coordination, and that includes sharing of data to some extent. Sometimes you need not go to the macro level, micro level, but there is a scope. For example, I'll just give one example for this one and share another example at the institutional level. At the ministry level, for example, Ujjwala Yojana had such a huge impact on the TB incidence in India in last 10 years, unmeasurable.
Air pollution, indoor air pollution.
Yeah. The global indicators which WHO reported, the information, if you look at the access to the clean fuel and indoor pollution being a most important population attributable fraction in India, has tremendous improvement. Once upon a time, it was less than 25%, 30%. Now the access to the clean fuel is more than 80% now. So you can imagine the amount of contribution that it has happened. And you would hardly find any paper, because we are usually entangled into things which we are known to us, which are visible to us, and we try to do. But that is what needs to happen, and I think there is a role for ICMR also to work and do research on it.
Well, thank you.
Yeah.
No, sure, please.
The second is the institutional level. Shamim tried to give a flavor of it. What we attempted was, for the Northeast, which you know that the difficult and area and terrain, we tried to identify all the national institutes in Northeast and tried to bring them together under the Northeast Council, all IITs, IIM, ISRO, all wonderful institutions, and try to bring them as to how they can support for the cause. And of course, the formal MOU and things keep on happening, but they have moved and a lot of synergy is there. So it's not just the information of the individual citizens and the patients, but it is also the intelligence that we bring in from different institutions, which can actually propel and push all our efforts in the right direction. That is what is important. And my last point is, 10 years before, when I told my friend that you don't need to carry now the driving license, your motor vehicle registration, he just laughed at me. What are you saying? This is not true. Then I showed him how to do it, how to make it in a digital archive, and how we can use it. And still it took almost 2 years, 3 years for every policeman, traffic constable to believe and use that particular system. But anyway, from that, taking it forward, next 5 years, 7 years down the line, I see that almost all the information of the citizens will be there linked with a central Aadhaar-based locker, and therein is no question of merging the data and synergy and integration. All these things will evaporate, and that's where the lot of I can say mounting of monitoring and evaluations from individual level to aggregated higher ups will be helpful for the program as well.
Thank you very much. So I'm going to ask a final personal question to Dr. Vinay. I'm going to put you on this thing that we measure diabetes among TB and we report it. We measure HIV among TB and we report it. When will we start reporting severe undernutrition among TB? Because the burden is very, very high and we are just putting it, though interventions are there, but because we don't know what proportion are severely and very severely undernourished, we are not able to prioritize existing interventions for patients, and we're not able to look at equity in the distribution of nutritional services. And I'll not miss this opportunity, and I keep writing newspaper articles, but I think I request you that the TB program starts documenting, because in India, 30 to 40% of TB is due to undernutrition. And the deaths among severely and very severely undernourished is 4 to 5 times. In absolute terms, it is 16 to 25% when compared to 3 to 4% without severe undernutrition, which is BMI less than 16. Over to you.
I'll take more of it as a comment and an advice to incorporate. There is no denying the fact that nutrition is the best vaccine we have at the moment. And of course, malnourishment and occurrence and bad outcomes, they go together. So I'll take it more of a comment. Thank you.
So, thank you very much, guys. This was a roundtable discussion. So we were told that no comments. I leave it to the organizer. That's given in the SOP. That is a roundtable discussion. No comments from the audience. So I prepared. Over to before I hand it over, let us give a big round of applause to the panel here. Thank you very much. Yeah, over to you.
Thank you, Dr. Hemant. Thank you, all the panelists. Before dispersing, I would request Dr. Hemant to give the token of appreciation to all the panelists.
Bhavin, I'll begin with you. Yeah. Dr. Vinay. Thank you so much. Thank you for being such a wonderful. Amen. Dr. Kiran, back off. Last but not the least, my hero.
Thank you, sir.
Dr. Hitesh. Thank you very much. Thank you.